you basically pop the stick, you give it to them, they breathe it in, and it's got great pain control agents. And it's not a dose to induce anesthesia, but it's a dose to like really take their pain away. And it's not an opiate. It's not addicting. You can't go buy it on the street. It's not addictive. The problem is it's going to be super expensive when it comes out, right? So, but the way you address that is you get in with the company and you say, hey, you'd love to market this to EMS, right? Let's do a research trial together. You provide it for free to us for 5 years, which will take us the time to collect the data. And so that's how we would approach that. But methoxyflurane is absolutely like on our watch list. It's not opiate. And even nitrous, I mean, people are talking about it again, it's not opiate.
I was going to say the French medics in Africa
Yeah.
very useful.
Did they? Okay.
Your vapors will love that.
Do you want us to do anything differently with PCRs or like notify you if we use this? Or
I would love, that would be excellent, yes. So we don't have it as a trigger alert right now. We're not gonna know if you guys use it if you don't tell us, so please do. I mean, we want to see your charts, obviously, and use that in support of you guys having it. So, Chiefs, if you hear that somebody did use it, just let us know, that'd be great, so.
And I really don't have a good sense for how much we're going to use it too, so it'll be real interesting to see how much you guys find this useful to incorporate into your treatment. It's another example of how we give you a tool to put in your toolbox, but we look to you to utilize that tool appropriately. So I'm real interested. Part of me thinks we're going to use it like all the time, and after like 2 weeks we're going to say, man, stop emailing us constantly. Part of me feels like we're not going to use it that much, so I'm real interested to see how you guys think it fits in.
we've had 3 or 4 calls in the last month where we could have used it. So.
Good, I'm glad you guys are thinking about it. Obviously you heard that you were going to get it a while ago, so hopefully that's triggering in your mind. Have you guys looked at this? Have you seen the lidocaine overview? You have? Okay, well we'll burn through this real quick just to touch on a couple of points. So lidocaine is going to be used as an antiarrhythmic while amiodarone is in shortage. Once amiodarone comes back, we will no longer use it as a antiarrhythmic for our VFib, VTAC, or S. Lidocaine is a sodium channel blocker. It helps slow down electrical signals to make the heartbeat a little more rapid, or less rapid, excuse me, and more steady. It's not a one-for-one replacement for amiodarone, so it's only for VFib, VTAC. We're not going to be using it for those wide complex tachycardias that we would normally give amiodarone to. And then of course we still are going to use lidocaine. You've had lidocaine this whole time, but you're only using it for IOs, correct? Mm-hmm. For those semi-conscious patients. Contraindications, again, like I just said, we're not going to be giving it to people with a pulse. This is only pulseless ventricular rhythms. You're not really going to see these side effects much because we're not giving it to folks with a pulse. There is a lidocaine toxicity that some services have seen. Woodbury has a number of surgery centers there. We had a lady at the end of last year that got, you guys will have to tell me what the LAST syndrome stands for.
It's
Local anesthetic
systemic
toxicity. So she was getting, I think, IM injections of lidocaine, which I think inadvertently went into a vein. And she dumped her pressure and was kind of peri-arrest. So if you have somebody at, I don't know, the Health Partners clinic and was getting some sort of procedure and you notice that they got lidocaine and then dumped their pressure, it could be one of these adverse effects from that. There's not a lot that we can do about it. It's just supportive care. They can give lipids in the hospital to help reverse that, but again, we can't do that in the field. The administration, so you've got your VFib, your VTAC, you start good quality CPR, you get your IO, you give your epi. The next indication is for a antiarrhythmic. We're going to give lidocaine 100 milligrams. We're going to go through our algorithm and then we won't give the lidocaine again for 10 minutes. We'll give another full 100 milligram dose and then that's it. We're not going to give any more. If you're giving a second dose of lidocaine, hopefully what we've done is we've called ECMO, our patient is packaged, and we're driving down the road headed towards the hospital. So this would, your second dose would be something that you're doing while you're headed to the cath lab. If you have a wide complex tachycardia that you normally would give amiodarone to, but they have serious signs and symptoms, we would just cardiovert that person. So, make sense? Yeah. This is just kind of a team dynamic of the workflow. This is in your guidelines. I do want to point out that lidocaine is in the incorrect order here. It should, I think, be getting fixed in this guideline update. So you give your lido after 4 minutes, and then this says after 8 minutes. Just know, because this is in the wide complex tachycardia as well, this should be moved down to here. So if you see that in there, there is inconsistent with the recommendation I'm giving you today. These are the guidelines that you will see lidocaine indicated as an antiarrhythmic. And of course, the intraosseous. I think I missed mentioning it in the indications. It used to be 50 milligrams that you would give through the IO. That changed at some point, and it's 40 milligrams. So, like me, I always have it stuck in my head that you give 50, but just know that the guideline now is just 40 milligrams. Any questions on that? So when amio comes back, and I have no idea when that's going to be, we won't use lidocaine any longer except for those IVs.
There's one trial over a decade ago that looked at amio versus lidocaine head to head and shocked the world with it, and so amio's better. Lidocaine's not bad, still works, just wasn't possible.
Wasn't the trial sponsored by the lab that made amio though?
Is that, I don't know.
I thought that's what it was, but
Would you be surprised?
yeah.
Totally.
One quick operational note. If you've been to Regions recently, you will notice that it's all messed up. You can't get into the ER, like when you come off 94 here. You guys usually come up 35, but you can't get in right here by the ED entrance. You got to circle around and then come up through here. So.
It's gonna be a mess, thank God we won't have to.
Yeah, and I am sorry to report that this construction is going to be going on for about 18 months. So, what exactly are they doing? They're just redoing the...
They're adding tons of space, so we're having a whole new triage area, and so like basically like our triage area is just a patient care space now. We're so busy, it's not really triage, so they're redoing all of that. They're adding more beds, so I think we'll be up closer to like, I think it's like 80 beds we'll have in the ED from 60, so it's bigger, is basically what it comes to. Bigger, more space, all new triage area, safer triage area with like bulletproof glass and stuff. And just to mention your lidocaine toxicity thing, so just to let you guys know what we're doing in the hospital again to do the opiate epidemic. So nerve blocks are something we've really incorporated into our practice over hip fractures and rib fractures now. We're the standard of care in the ED is to do a nerve block. So that's something that's probably just new within the last year. It's pretty exciting though, they work really good. I love doing them. But that's something we're doing on the hospital side. And so yeah, we're all very, very familiar and aware of the lidocaine systemic toxicity. Toxicities. Intralipids, another thing I've always thought about, could we use in the field. But it soaks up all your other meds like epi and stuff. So yeah, you give this thing that's called intralipid to lidocaine toxicity. If you overdose someone on lidocaine with a nerve block, is how it always happens. You give this thing that's basically just fat. It's just fat bubbles, and so it sucks up all the lidocaine. The problem is it sucks up every other medication in your system, right? So, you know, the thought always is, well, what if we used it in like that undifferentiated overdose? You know, you show up and they overdose. Well, now almost all of those are opiates, right? Which we have good treatment for. And the intralipid's going to suck up any therapeutic meds we give, like epi or things like that. But that's something no one has ever tried, intralipid in the field. So I keep talking to our toxicology folks, like, let's come up with a way to use it. Let's come up with something we can do. But we're 10 years into that thought process and haven't come up with anything.
All right, let's go over a call with Greg, and who else was on it last Saturday?
Pretty much everyone in Misha, Ricky, Josh, Matt, Annalise, Ben. We had an EMT student.
Oh, good.
And Dave.
We'll all see it here shortly. I have lots of stuff. to show regarding this call. This was a great call. I'll start off with saying that the care that was delivered was very good. The documentation was also very good. So, can you tell us about it, please, Greg, or whoever else?
We were doing our fire training. We got a call for a choking at Serenity. I think it was a choking delta is what it came out as. On our way there, it updated just saying that staff was doing Heimlich, but nothing was coming out. And I'm like, well, it's Serenity, so either they shouldn't be doing the Heimlich right now, or it's gonna be something really bad, and there's nothing in between. Arrived on scene, kind of walked into the room, took one look at her, and was like, they should have gone to the floor and started chest compressions probably a while ago. We have a lot of staff and some family in the room. They have her on a couple liters of oxygen. I can hear some stridorous respirations, so I brought our arrest bag and our monitor in, and I was like, we could work this in the room, but I would rather get it to the environment where I have more control and we're away from family especially, who was there. And so we just tossed her on the cot. I cranked the nasal cannula to 15. She got up into the 90s.
Good.
Quick on
Good.
pulse ox, but still really struggling. Got her out to the truck, had to pull our engine at that point. Put her on like non-rebreather, put an NPA in to try to do the best, keep airway open. Realized her jaw was really clenched, so we just kind of talked through and we're like, we're gonna have to paralyze her to even get McGill's in there to try to remove this.
Perfect. So
we're just gonna tube her immediately after and we're gonna run with it.
yeah, so knowing that you're probably headed towards an RSI route though, so starting pre-oxygenation as quick as possible to get those sats up.
Well, BLS before ALS, like that's perfect, right?
Always.
That's exactly how it should be done.
Always, yep. So stridorous respirations, thinking upper airway obstruction for sure. Well, do you remember what her vitals looked like at that time?
She was like 150s over 90s. On our high flow, she was like 94 to 97%. We started assisting BDM and we were up in the high 90s the entire time.
Okay.
GCS was like, I estimated a 6, I think, when I walked into the room. And I mean, like, when I didn't flush with the Lido, I just did a saline flush for the humeral IO, and I got just some withdrawal of the pain and not really much else.
Yeah.
Out of her, so she was pretty obtunded.
Yeah. So it had been down for a little bit.
Yeah. And then staff said when they put her on their monitoring that they had the little vitals on wheels thing, they had as low as like a 40-something% for saturation. We're only able to get her up into the 70s before I just cranked the O2.
You know, I think that just one thing about like IOs and awake patients, when someone's sick enough we're putting an IO on an awake patient, I'll be honest, like I have never given lidocaine through an IO in an awake patient. Because by that point they're dying and like it's gonna hurt for a second. It can be diagnostically helpful to see what they do to that painful stimuli, so that's useful. But you know, in this line of work, sometimes you gotta cause people some pain to get them better.
I just realized I need to fix something that second IV should be unsuccessful as well. So I had 2 people try, and she just didn't have good vasculature, so I just drilled her.
So the Heimlich, you do the Heimlich on people that are still somewhat conscious, right? And at what point do you put them on the floor and do chest compressions? Yeah, when they go unconscious, for sure. Yeah. All right, so you got her out to the truck. Got your humeral IO. Kudos for that.
Then we did 250 ketamine, because I was like, this will probably be long to both get a piece of food out and then get a tube in, so I want a longer sedative effect.
Yeah, rather than etomidate or a lower dose. Yeah,
And
for
so
sure.
we did 250 ketamine and 80 of rock, because we were estimating medium dosing, I think. And as soon as she was nice and loose, had my EMT who's doing the backing pull bag off, I put video scope in. I utilized it more like a direct fashion, like I was looking direct versus at the video to pull the piece of food out. And then transition back to using the video to tube her.
I came from a time when we didn't have video laryngoscope, so that's kind of my default, is to look into the mouth versus using the screen. And I think that you have better technique when you're using your video scope almost like direct. You use the blade typically how it's designed versus just looking at the screen. So one thing that happened when all the services moved to video laryngoscopy, excuse me, is that the first pass success rate went way down. And I think it's because people were trying to tube the screen instead of tube their patient. So using that Mac blade as it's intended, moving down the tongue and getting into that vallecular space so that you can lift up and actually see the tracheal opening instead of just seeing it on the camera. If you can't see it through the patient's open mouth, it's around the corner and it's going to be harder to get to. When you have that big perfect view of the chords on your screen without having the epiglottis at the top of the screen, typically you're too deep with that blade, even though you can see it on the screen real good. If you look in the patient's mouth, you can't see it. But if you do direct and you're looking for those landmarks through their open mouth, usually you have better success and you don't have to round that corner with the bougie or the tube. So you did seem to do that pretty well. We'll skip to the good stuff here.
I think,
It's right around the 7-minute mark.
yeah.
I've watched it a few times. I showed it to a few people.
And I think when we first went in, I kind of had to back the tube up, or the blade up a bit because her dentures on the bottom were starting to fall off and moving where the tongue and her jaw was around, so we had to pull out just a little bit, get those out of the way, and then I was able to go back in and finish my work.
Yeah.
It's right here's where the dentures were starting to move around and give us problems.
That's a significant piece of chicken. So you can see your epiglottis right there, right at the top. There it is, right there. There goes the chicken. Were you feeling a little resistance there?
Yeah, this was one of the first times I'd used the rigid stylet for it, because I know it's designed for our hyperangulated blades. And I was trying to communicate with, I think it was Matt, sitting next to me, to pull the stylet a bit so I could slip the tube.
Yep, absolutely. So if you just pull that thing back like an inch or 2 inches, it should move that tube in a little better position.
I kind of wanted to try it because I was like, I know how to use it. I'm just going to see. I like the bougie a lot better. I don't think I'm going to use the rigid much more.
Yeah.
When I'm using the rigid, I have like my thumb kind of right at the,
Yeah.
on it, and then like once you're at the cord, you're just gonna like pop it a little bit.
Yeah.
I know we talked about trying to get you guys Mac blades, but they don't sell them for the particular scope that you have. So I don't know if that's
Looking at the monitor, because I definitely just threw those.
that was pretty good though.
Yeah, I mean, just seeing that one waveform, I mean, then you know you're in it. No debate, no question asked.
Yeah.
And her end title was in the mid-50s to 60s, I think, initially. We breathed her down just a little bit, and then we're maintaining mid-40s the rest of the way. Desatted en route.
Yeah. So let's talk about that. So your tube's in. Did you have waveform still? Okay.
So
So
the first thing I looked at is I'm like, we're still ventilating.
yep.
We're dropping really, really quick. Annalise had stethoscopes, so she listened again, and it's like, I don't hear lung sounds on the right side anymore. I remember staff had said, I think we broke ribs when we were doing abdominal thrusts because they felt cracking, and they were a little high on her anyway. So I was like, well, it's probably not right main stem, that would be, or I mean left main stem, that would be really unusual. So I was like, screw it, I'll just double check, make sure oxygen's hooked up to the BBM, like
Yep.
it was flowing, it was high.
So you've got good capnography, right? So you're having trouble with your tube right now. Anybody remember back from medic school the mnemonic? DOPE. So DOPE is one of the few mnemonics that I remember from medic school because it works very well for whether it's an RSI or any intubated patient whatsoever. So DOPE, I can write on this, yeah? So who can tell me what the D stands for? Yep, dislodgement, displacement. So did it come out Did it get shoved down into the right main stem? So looking to see where that tube is. If it's this far above your tube holder, might have pulled it out, right? If the hub where the BVM connects to is right next to the tube holder, probably went main stem or into the esophagus. So displacement. O stands for obstruction. So is there crud in that tube? Is there like mucus or chunks of chicken in there? So using that soft catheter, not your rigid hard catheter, but dropping that soft catheter in there, remembering that you bury that thing first and then plug it with your thumb and then pull it out. P? Pneumo. So you're going along, you got waveform, but all of a sudden the bag is a lot harder to squeeze. You want to listen to lung sounds. Maybe listen for a pneumo there. E stands for equipment. So that's the one that I've ran into a lot. So let's say you're driving down the road, you've got a nice capnography waveform, and then all of a sudden it goes flat. That doesn't necessarily mean your tube is out of place. It just means that you need to reassess your patient. So did the capnography probe back out from the side of the monitor? That happens because it's kind of screwy how you put it in there. Did the tubing that goes to it plug up with gunk or that sort of thing? So you'll never get a false positive on my ugly capnography waveform there, but you can get a false negative, right? So just because your capnography waveform went flat doesn't mean your tube's out, it just means you need to reassess it, right? So remember that dope mnemonic, which I think you handled very well. So which one of the DOPE was it?
It ended up being an obstruction, just because I heard staff mention the ribs cracking and we had lung sounds that were absent on the side that I wouldn't anticipate. I threw ultrasound on just to look. Moving down the road, it was really hard to see, and I also got some of the gel on the screen, so it was really hard for me to assess the gain and the depth, so I was having a hard time really, but it didn't look like there was much on the lung sliding. I put it in M mode, and I didn't see differentiation in the M mode for like the sand on the beach thing.
Sand on the beach, yep.
So I was like, maybe it's a pneumo. I was getting ready to head down the path, and I'm like, I'm just gonna suction real quick before we look at even popping a chest or doing anything.
Yeah.
Just to give it a shot. Threw it down there and I pulled some more chunks of chicken and stuff out, and her SATs went right back up.
Good. Awesome.
If that didn't work, you were gonna do it.
Yeah, I was going to, yeah.
What is, so our fail-safe is always, if you troubleshot everything, you can't figure it out, what do? You pull the tube if you have to, fall back on your BLS measures, always BLS before ALS. So take that tube out, put in the eye gel, but make sure you do your diligence here. That's not while your patient is totally desaturating and starting to circle the drain, but before you pull the tube, try to go through those.
Put the link, just go back and look, that's the beauty of video. You're like, hey, we all agree, that's going through the cords. Or yeah, that's going through the cords, we're good. And just remind people, like oftentimes we hand the bag to the least experienced person after you get the tube in, and just remind them, like, hey, this feels different, you gotta let me know, okay? And so like when I'm taking care of these patients, I squeeze the bag myself. Like I take the respiratory therapist and I'm like, I need to feel this, and then I feel it. So it's really important what you feel when you bag, because we don't have a ventilator to tell us pressures. That's probably one of the biggest things a ventilator tells you, is just what are the pressures doing. If the pressure's going way up, well, it's either an obstruction or a pneumothorax. Pressure's going way down, well, it probably got displaced. Our pressures are feel pressures, and so even if you are the one intubating, get a couple feels for what that bag feels like to start, so when you reassess, you know what you started with.
Yeah, like Aaron said, we have a tendency to hand the bag to our student that's with, or the cop that's with. Check in with them often, for sure, to make sure that their rate is still good, that they're squeezing the bag, getting enough tidal volume in there, and that it's still going good for them, so.
Like if we don't have a patient on the ventilator and I'm taking care of him, I'm asking like every minute or two, like, hey, we're doing okay up there, he's easy to bag? And they're like, yeah, easy to bag.
Yeah, so keep them in the back of your mind. So you got 2 regions. You called a red medical?
I think so.
Yeah, I think it's very appropriate. I don't know what other, she's certainly not a TTA, right? None of the other activations, so red medical is super appropriate.
So let's throw a little wrench. What if you're getting there and then they hand you a DNR? So how do you do that? How would you work this case? And there's not a right answer. There's a lot of ways to approach this one, so let's just talk through it. So you got a patient in a nursing home, memory care, you know, kind of towards the end of life, now having an acute event that
That's-
maybe is fixable, maybe not, and you got a DNR. So how would different people approach that? There's not one right answer.
I don't think, well, me pulling a piece of chicken out of someone's mouth is not DNR. DNR
Right.
telling me not to resuscitate them, so
Yeah.
you can remove that chicken and
Yeah.
breathe it on their own.
Sure.
You know, obviously if they do have, you know, do not intubate, obviously we're not gonna go down that route, we're just gonna try to remove into obstruction and see if they proceed to make it on
I couldn't agree more. When that family is deciding to put the DNR on that patient, do you think that they were thinking about that patient choking and dying? Not at all. So if there's a life-saving measure that we can do quick versus just working a whole cardiac arrest, if we can pull a piece of chicken out of their airway, absolutely we should do that. So.
Yeah, so let them know, like, hey, I think this could be really quickly fixable, and then they get back to how they work. You know, that's what you want to let them know, versus, same thing, if you're like 20 minutes into an arrest and they don't have a DNR and they have advanced disease, you can also say, hey, you know, if the family's getting upset, it's okay to say, have you ever talked about this with them? And then when you call us on the radio and say, hey, I got family here, they said, you know, we're 20 minutes into the arrest, but they want us to stop, the patient wouldn't want this, we've already done all the easy to fix things, we give it a dose of epi, we've secured the airway, families telling them they wouldn't want this anymore. We're going to back you up every time. So there's always a gradation, you know, and this is what I run into families. Like sometimes a 90-year-old is still a full code, so I go down a little ways and you try the first easy thing. You secure an airway, it's not shockable, you give them a dose of epi, and then I start talking with the family. Like we've tried the things that are most likely to work, and they didn't work, and this is getting to be more and more dire. And you can have those conversations with patients, just always run it by a doc before you stop. But I think we would all be very supportive of that.
Know that when you call for a doc too, that's going to take a little bit of time, right? So if it is that patient that you have a feeling this is not going to work out very well, get on the phone, expect that you're going to wait 2, 3, 4 minutes for a doc to get there. So.
That would be an interesting one if it had been this patient, because we didn't have a choice but to paralyze to be able to pull the chicken out, so we were going to have to tube regardless.
What was family saying to you on scene?
They were just kind of there.
Okay.
I didn't get a chance to talk to them much because I was in the room for all of maybe a minute or two.
So they didn't give you any
It was
indication of what they...
Outside the ambulance, they asked, are you guys going to the hospital right now? And
Okay,
they're inside, I said, they'll probably be here for maybe 5-10 minutes to make sure we stabilize or figure out what we can do.
Good.
And I kind of directed them to start heading to regions.
Good.
So they weren't like, don't do anything, they're just like, what should we do next? They're kind of looking for direction.
yeah, perfect.
I didn't
Good.
have too much of a chance to interact with them, or even really staff. I was just like,
Yeah.
just start moving and doing stuff, and I don't have enough resources right now to do what I need to do.
Good.
So staff did get his paperwork run out to us. They hadn't had a chance to print it off first, and it did say full code up top. So, and Rachel confirmed that. So
Yeah,
that's
that's
why
first thing I was like, looking for code status.
Yeah.
The other thing I'll say to families is like, hey, just because we put the tube in now doesn't mean it can't come out whenever you want. So, because you see this too with like people who have pneumonia, you're like, maybe we can with 2 doses of antibiotics, they're gonna pop right back, but if we don't put a tube in, they're gonna die. And so that's like, again, I don't wanna make this too complicated for you guys in the field. Sometimes the conversation I have with families is like, do you think they would want to give it 24 hours? So we can put the tube in, we give them 2 doses of antibiotics, and if they're not clearly getting better, you know, we can give them some pain medicine and take the tube out at that point. So that's another thing you can say to families. Just because we put the tube in here, you can decide at the hospital at any point that they wouldn't want this anymore, and you know, you can talk about that with the doctor. So it's very individual. So if there's time, like in the hospital, if we're clearly either headed towards intubation or death, like I'll have a discussion with them about, well, let's set some goals before we do this. And you try to involve the patient if you can, but you know, usually you guys are in more of an acute emergent setting. But I'll even say to the patient and the family, like, let's talk about what we're gonna do. If we put you on a ventilator, do you want to give it 24 hours? Do you want to give it 3 days? Like, if you're not getting better in 3 days, I can tell you, given all your other medical problems, you're probably not going to get better. So should we say we're going to give it 3 days, and if you're not clearly getting better in 3 days, we're going to take you off the ventilator and we'll let you die. We'll let you go. keep your pain under control and all that. So that's another thing I try to do, is set expectations before we pull that intubation trigger in people that are like in the middle, where you might get better. I mean, we might hit this with some antibiotics and the bacteria goes away and you pop right back up. Versus someone who's having a huge STEMI and they're already in terrible heart failure and you're like, this is not gonna get better, right? Let's keep you comfortable.
Had this same patient been DNR just because she wasn't necessarily super unstable and we were oxygenating well, I probably would have called first before doing that then. 'Cause it's like, we're gonna have to RSI her to get this out, but this could be an acutely fixable thing. Do you just want us to BLS it to you, or do you just want us to